Now, we didn't touch on early in the conversation about the life expectancy of sickle cell disease. And so we have pediatrics here, we have adult hematology here. And in pediatrics, it's beautiful, right? You do a great job, they take their hydroxyurea, they live to be 19, 20, 25, and then they move on to adult care. And you just mentioned that after 30, 40 years, it's not so rosy, right? So Julie and Matt, what do you guys see in terms of the mortality you see in your young adult population?
Yeah, so as you mentioned, we are still seeing what I would kind of call a spike in mortality in our 25 to 35-year-olds. And I think there's a lot of reasons for that. The biggest issue, it seems to me, is a difficulty in coping not just with the disease, but the independence that's associated with being a young adult. Adulting itself, right, can be hard. Adolescence is a horrible...
It is hard.
Adolescence itself is its own disease. But also just the idea that they're going to have this disease and coming to some form of balance and acceptance, and an acceptance that they're not going to fight it, but they're going to learn to live with it. And just like anybody else in college, they can't go out and party every night. And that can be a really difficult thought, that not only can they not party every night, but maybe they can't party like their friends, because that, burden will increase their stress and cause them to end up in the hospital. The other thing, though, that I think is really crucial to bring up is a lot of my young adults are dying because they're in hospitals where providers are not as familiar with the complications of sickle cell disease. And I really want to reach out to providers and say, if you ever need anything, please call me. If you have a question or there's a complication that looks different, you're not familiar with it, that we want to make sure we get these individuals to a center that can take care of them, because I do think frequently they end up in community hospitals, and everybody wants to do the best by their patients, and they just might not be as familiar with sickle cell disease. And that period of young adulthood is especially stressful, and so I think those patients are in the hospital more, and it poses more risks.
Yes, and I think there are not only disease-related factors that can potentially be contributing to that spike in mortality in terms of the accumulation, the inexorable accrual of organ damage that we've talked about coming to some sort of threshold. But I also think there are other systemic aspects to it. Getting older is harder. What comes along with now job insecurity, school, housing insecurity, food insecurity, all of those things come to a head in young adulthood, the loss of insurance potentially. The definition of disability in our country really thinks more about static disability, like a transected cervical spine, as opposed to sickle cell disease, where patients can be completely disabled 5% of the time, just long enough to lose a job, just long enough to fail out of school, but not long enough to get some benefits in terms of Social Security.
That's a very good point.
So it really, there's systemic aspects to it as well. But I think it seems, I think, from the young people I've spoken to, like serial abandonment. They lose their pediatrician, then they lose their pediatric hematologist. They have to go to a new care facility that they may not immediately kick it off with their new physician, and we beg them to give. No, we just beg them to give it a chance and to really solidify their new medical home, because that's what's so important for their long-term success.
And by the time they come to you, they're they're on the down spiral.
In terms of
disease progression, complication rates, accumulated damage.
Well, I'm seeing a change though.
Lack of care.
Yeah, but you know what? Oh, you mean those who have been out of care, not necessarily transitioning directly from the pediatric hematologist office. You're absolutely right. So I see two populations of patients. I see those who've been well tucked in by people like Matt in the pediatric programs, who are on their hydroxyurea, who are on their transfusions for stroke prevention, that are all vaccinated, that know their history, know their alloantibody status. And then I have those adults that I've acquired through community outreach, who are in their late 20s, 30s, 40s, 50s, and beyond, who are really in a bad way. Retinopathy, partial blindness, if not complete blindness in one eye, bad avascular necrosis with serious pain, liver disease, pulmonary hypertension, you name it, because they have somehow grown up thinking that, well, first of all, not having providers available to take care of them has led to this problem, thinking that, well, I'll just live pain crisis to pain crisis, and when the pain crisis is over, I'll get on with everything that was on hold, but they don't always know that things are happening in terms of under the radar. chronic organ damage is developing. So we have a lot of improvement to do.
We have a lot of work to do.
And I really think some of that needs to start more in pediatrics. You know, as a lifespan provider, right, I've taken care of kids and adults. And I think it's really important, though, that we really start the conversation about preventative care. Pain is important, and it certainly affects quality of life, but understanding that this disease isn't all about pain. And we have to address, you know, the issues that are going to cause mortality, because those are what we want to, you know, when they're still listening to us when they're younger, we want to make sure
Make
they
an
understand
impact.
that. Right, exactly. And then
Get through to them so that they can have that and kind of grow up with it.
exactly.